when you look at the perioperative patient safety, the role of anesthesiologist, importance of quality control for improving clinical outcomes, and redefining surgical patient experience. So with that, I'll ask the first speaker to speak on the perioperative patient safety role of anesthesiologists.
Thank you so much, sir. Pranams to everyone, and at the outset, I would like to extend my very sincere thanks on behalf of the Indian Society of Anaesthesiologists, for which I have the current responsibility as the president, to thank CAHO for creating a tsunami in healthcare in this country. I wanted to, all of us together, applaud Dr. Vijay Agarwal, Dr. Lalu Joseph, and CAHO team for this phenomenal contributions in creating an awareness and a platform to make sure we prevent the preventable deaths in whatever form it's possible. And thanks for giving this opportunity to speak on the perioperative safety, the role of anesthesiologist. And I'm also very happy that the Indian Society of Anaesthesiologists have joined hands with CAHO. And thank you to Dr. Lalu Joseph for spearheading, bringing in the book, The Essentials of Safe Anesthesia, which was released today, which is the first step towards patient safety, and all the stakeholders, including the paramedical staff, the anesthesia technicians, the anesthesia postgraduates, would have to go through this, which would create an awareness about patient safety in the perioperative period. And also very happy that we have several collaborative projects together, including environment sustainability in the operating room, the PCPNDT Act and its effect on anesthesiologists and perioperative outcome, and we look forward for future collaborations. Safety in the perioperative period is very crucial and important because a patient walks in for a tonsillectomy and without even having 1% clue that the parents will not be able to take this patient back home because they thought it's a simple tonsillectomy. And if it happens to be negative and we lose a patient who has come for a tonsillectomy, this is the biggest, I would say, even in this modern era, an episode like this is the biggest catastrophe to humankind. And thank you so much for CAHO for joining hands. It becomes important. Does protocols make the difference? Does systems make the difference? I personally feel both are important, but I think more important is every single healthcare provider should introspect and give the best to the environment in which they work. And for that, we need to introspect. When we are born, we are all born as equals, but human glory lies in ensuring that we do not die as equals. For all those who got the award today, there is a big sense of happiness because they've created something and they've accomplished something, and they are no more equals, they are one step ahead. And this is a slide which I wanted every single of us present here to introspect on this statement. We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution. We may be born to illiterate parents, but we can die as scholar of world repute. We have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be, and we can be what we choose to be. And this is exactly these kind of statements, when it is driven deep inside, then we will look for perfection and we will see medical errors, negligence never happens. And for doing all this, we need to set our core values. We need, all of us wanted to be successful, but success is all about being in the process of joyfully creating a life that reflects our highest values, our deepest beliefs, and greatest dreams. God created healthcare. He produced a human life and created a healthcare system to preserve life. So each one of us sitting here are part of a sacred mission of God. And our work should be our prayer, because everything that we experience, from the food to the cloth to the shelter, the comforts and the luxury that we enjoy, are all the rewards of the work we do. So we tell all of our anesthesia postgraduates that we revere our workplace, and our workplace should become our prayer. And it becomes very important and crucial that we take examples from our day-to-day life. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, a 650-bedded tertiary care referral center for trauma, orthopedics, and major reconstructive surgery. And I also bring to you greetings on behalf of Indian Society of Anaesthesiologists, with 49,000 anesthesiologists present over 240 city branches across this country. And we have developed a protocol and a workshop, a simulation-based learning on the 6 common causes of perioperative morbidity and mortality in this country. And we have signed a MOU with 34 centers across this nation to create awareness among anesthesiologists on the common catastrophes that happen, which results in significant morbidity. We wish to collaborate with CAHO on this, and we wanted to patent it and take this across the country to decrease the mortality and morbidity. I currently also serve as the Secretary of the World Federation of Society of Anaesthesiologists, which is a conglomeration of 150 member countries. And here again, our mission is to have universal access to safe anesthesia and to unite and empower anesthesiologists around the world to improve patient outcomes. This is a very important statement for each one of us. It's not the strongest of the species that survive, not the most intelligent, but the one most responsive to change. India was like this when we got independence. And now what has happened to this nation? It's got the largest sea link, the modern downtowns, putting Chandrayaan on moon. So the best way is to say yes to the technology. And in anesthesia, we embark on the journey of all these new gadgets which has come in, technology to empower an anesthesiologist to give anesthesia to critically ill patient and make them live. The ultrasound guided nerve blocks, the point of care ultrasound, the target controlled infusion, the workstations, the neuromonitoring, all has come to supplement and complement the skill sets of an anesthesiologist to give the best to their patient. And hence, ASA grade 4 or the critically ill patients go home today because of adopting the new technology. And the next thing we are embarking on is to make every single anesthesiologist as a perioperative physician. And to do that, they need to know a lot of medicine. We wanted them to be the single point of contact as a physician to do a proper preoperative assessment of the patient. And for this, we need to be extremely knowledgeable. And we teach all the young postgraduates to become extremely skillful, because when skill and knowledge joins together, there is clinical excellence. And along with this, if we keep on updating, we really move on to the next ladder, not only for anesthesiologists, but for every one of us here in whatever spectrum that we are working with. So along with this, we need to create youngsters who believe in what we do, and we need to engage in a lot of clinical audits and research. And I'm very happy that CAHO has embarked in the journey of clinical research. It's also very crucial and vital to have the cross-pollination. We need to visit centers of excellence to see different practices that are being done in the perioperative care. But I come to the basics. I think it's very strong self-discipline we promote among our anesthesiologists, because until they sleep well and come to do a surgery, they can't even start an IV line properly. They make mishaps in intubations. So it's a dictum that all of us, to focus well, we need to have excellent quality of sleep. And we also preach on certain personal traits like phenomenal integrity to what you do. Because when you scrub for giving a spinal, just you only know whether you scrub for 3 minutes. So we need to integrate that integrity into every single one of us, that we need to be the same whether we are watched or whether we are not watched. And I wanted to share that when we do a lot of audits, we have found out that the compliance rate of even this wash is not adequate in several. So we need to keep on emphasizing all this. But we wanted to produce an India where every single individual will exceed his expectations by extremely being skillful, being extremely knowledgeable, and along with that, to have tremendous integrity to the system, the patient, and to be extremely honest and humble to achieve his excellence. We have defined the qualities of an ideal anesthesiologist, but we tell them that please begin with end in the mind. You see a patient and you want this patient to go home. And for that, when you do a proper pre-anesthetic evaluation, you play a game of anesthesia the day prior to the surgery, where you look at, you dream it, you see what kind of anesthesia I'm going to provide. So you're mentally played it before you physically do it next day. I think this is the biggest lesson that we wanted to teach everyone: where to start the venous access, what intubation I have to do, what gadgets that I have to keep ready. So you have to physically do the procedure, but you should have mentally worked on it the day prior. And this is what happens to all the peak performers. Vishwanath Anand, when he was the chess champion, he played his opponent several times the day prior mentally before doing it physically. So our performance will enhance if we do this mental model, and this would result in quality anesthesia, which is defined in 6 domains. It should be effective, equitable, timely, efficient, safe, and patient-centered. So we in our institution embarked on the journey, and anesthesiologists took up the role of perioperative physicians and in trauma resuscitations. We have been able, within seconds of arrival of a polytrauma patient, looked out by the anesthesiologist, point of care ultrasound done by anesthesiologist, resuscitation done by anesthesiologist. We don't wait for radiologists to come and do an ultrasound abdomen. If there is a splenic rupture, explorative laparotomy, the time they come in to take it inside the theater will be within minutes. On arrival, we make them ultrasound guided regional blocks, and we have been able to embark on this journey to provide such high quality, site specific analgesia for even sick patients. I don't want to elaborate, but these are all patients who are so sick and they can't be given general, they can't be given spinal. So we use the technology of ultrasound guided site specific anesthesia. A patient who would have otherwise died undergoes a surgery with effortless ease. So adopting a technology, learning the skill, and using the knowledge and the skill and the wisdom that is needed in every single patient is the one which would result in a great outcome. And we have learned informed consent, and taking the patients into confidence is important. We embark on the journey of telling every single anesthesiologist the need to prevent surgical site infection. And it's a dictum now that we need to see the patient in the preoperative period, do a proper anesthetic assessment, understand all the comorbidities and the drugs that the patient is taking, decide on the pre-medication and the preemptive analgesia that you give, clear strategy, what I'm going to do in the intraoperative period, the kind of anesthesia,
Excuse me,
the
Dr. Bala,
hemodynamics that's
we are...
produced. Yeah. And a postoperative consents, everything would be addressed, taking into care the multimodal analgesia. In a nutshell, every single patient who comes to us deserves the best, because each one of us wanted the best in life. And when the patient gives his own life for us to take care, I think we need to contribute effortlessly and make sure that we achieve the status of being a best anesthesiologist by closing all the gaps that we have in terms of knowledge, skill, and protocols. And I'm sure we will be able to send the patients back home very safely. Okay. And I would wanted this endeavor to be taken care along with ISA and CAHO together in the years to come. Thank you so much.
Thank you, Dr. Venkataraman.
Thank you, sir.
Just summarize, I think so. You rightly mentioned, for any surgical patient, the role of anesthesiologist transcends 3 areas. Which you highlighted is the pre-op, peri-op, and the post-op. And the concept of the perioperative surgical home has just started now, and many hospitals in USA, Europe have started using it, because they take care of the patient right from the time of admission till discharge. So they become the common thread for a patient and the relatives. So it's a complete teamwork. So that way they support the patient, the relatives, and it helps because in a hospital there's a lot of time the patient and relatives don't know where to go. So this common thread is where the anesthesiology plays a great role. With that, I'll hand over to Dr. Aparna.
Yeah, so without a further ado, great simplified PPT, and thank you for sticking to the time, sir. Thank you so much. I am inviting Dr. Aashish Chaudhry for an interesting topic of redefining surgical patient experience. He is a managing director of Aakash Healthcare, New Delhi. Over to you, doctor. Can we have the slide and the timer? Thank you so much.
Thank you so much for the kind introduction. Well, the clock is ticking, and summarizing my patient experience as a surgeon in the OR spanning more than 18 years in 12 minutes is a little difficult, but I'll just try to put the context and the growth path which we have seen apart from just learning the technique of operating a knee. So I'm a joint replacement surgeon specifically, and coming from a mere surgical procedure to actually getting a collaborative approach all these years, there has been so many learnings which I have summarized in few slides. And let me tell you, the first joint I did in 2010, and these 15 odd years, gradually I realized the numbers were increasing every year. But the fear factor and the patient problems, they were not ceasing to exist. Every time, I used to operate a single knee, patient never used to come back for the second knee because of the horrible, painful experience they had the last time. Although the x-rays were fine, the range of motion was good, and everything was fine according to radiology, laboratory, clinically, science-wise, but patient was somehow, they were not happy. That made me thinking, is there something which we are not fulfilling, or there is something additional have to be done? So put the context, I think I'll start with a story. One of my friend's father got operated for a brain tumor from the best surgical hand, great facility, best preoperative preparation. Flawless surgery went fine, post-operative CT scan showed complete removal, but ultimately, as we speak, the patient is more or less confined to bed, hardly eating, cardiac functions have went down, multiple admissions because of medical issues, GI bleed, sepsis, and all those things. So ultimately, even despite having the best surgeon in hand and great facility, the outcomes are still questionable. So what many a times, just like any other specialty, we also look at a procedure like, for example, a knee replacement as a surgical procedure, but we forget to look at many other aspects which might be affecting the outcomes, the ultimate outcomes. Patient may not be happy with a great looking X-ray, but unless and until they can go back to the same, the activity or the expected outcomes, they usually feel disappointed at the end of the full recovery. So as a result, we thought there has to be a holistic approach to try and reach the expectation of the patient and reasonable outcomes, which we have envisaged even before the procedure. So whenever it comes to a TKR, a lot of my family friends, they come with their loved ones and they want me to operate. The first and foremost thing is that it has to be a safe and a successful procedure. Rest of the things, whether we are going to have a luxury room or a robotic procedure or some fancy post-operative patient-controlled anesthesia equipment or any other things, those come secondary, but ultimately everybody wants a safe surgery procedure. And what I fear is, of course, X-ray is looking good, but patient is unhappy, chronic pain leading to a bad experience, and sulking in all the years after the procedure. Sometimes robotic procedures can also go wrong. Though we committed a minimally invasive procedure before surgery, but the outcomes were really horrifying. And a lot of medical comorbidities pushing the patient for repeated admission, hyponatremia, hyperglycemia, chronic infections, deep infections, superficial infections, so many other things. So there are many factors, many variables which come into play when we are telling the patient about the surgery. These factors, sometimes they crop up and affect, and one dissatisfied patient stops 100 other patients coming to us. So a usual typical patient journey starts from symptoms, going and visiting the doctor, getting the diagnosis made, and then going for the treatment plan. And if it is a surgical procedure, then from PSC till the post-operative ICU care or the HDU care, and then finally getting discharged and going for the rehab. But whenever this happens without a coordinated team or a plan in place, things can go wrong in any which way. So that's how, after going through multiple procedures and a lot of feedback from patients, we thought, let's have something which should, more or less cover all the factors. So we came up with a program which doesn't actually mean a speedy procedure. It just means we're trying to fill the gaps. First and foremost is the safety profile. How do we make sure that patient doesn't end up dying or getting another comorbidity which he or she was not destined for? And how can we make it more and more pleasurable and painless experience? How do we make sure that the procedure lasts a lifetime? And how do we make the patient go back on feet at the earliest? So these elements, of course, they fall into the Kaizen principle. And why I specifically chose this principle, because of all these factors. We realized that we were giving blood to almost every patient. So is there a way we can reduce the blood transfusions? So we brought in tranexamic acid, we avoided drains, putting up drains, and that gave us, and then tranexamic acid in the preoperative area. Then focusing on the diet, essential amino acid, curcumin came up very handy as a Ayurvedic component, but really helped patients recover faster, have better immunities. And of course, the most important part, anesthesia part, which of course every surgeon forgets to even consider worthy. But we realized that the pain was causing all the disability after the procedure, and we were not able to control it despite giving all the NSAIDs and opioids. And then came the rescue blocks, peripheral blocks, and that gave us a sigh of relief so that we can focus more on the rehab part and changing the physio protocol. And that's how we found that the experience starts to change. And we created a dedicated recovery unit rather than sending the patients to ICU with all the ventilated patients. It was a better looking and a more friendly environment where patient recovery was much faster. A loss reduction started to happen, and then going from a muscle cutting to a muscle sparing approach, and bilaterals, of course, gradually came down depending on the comorbidities. And then the robotics and technology were adopted very slowly, so that ultimately, if the functional outcome is not getting impacted or improved, we don't usually adopt the technology. And of course, from the implants perspective, we found that Indian made implants also made a lot of difference, as if not superior, but they were equally performing as the Western counterparts. And then we followed all the ERAS protocols for getting the better outcomes. And this is where we landed in those 4,000 odd patients we did. The patients were getting ambulated in first 6 hours, and use of NSAIDs, significant reduction, almost by 70%, and average length of stay coming down from 5 days to 3.65 days, and in a unilateral and a bilateral from 5.6 to 4.2 days. And VAS scores were all-time low despite post-operative day 1 or 5. And all these patients, they're coming from various backgrounds, so the protocol was getting implemented everywhere. And despite having an implant, which of course designed outside, but made in India, and giving better results than the Western counterparts. So I strongly feel that SpeedKnee program gave us an opportunity to review our plan time and again, take the patient's feedback critically, and try and go back to the drawing board and see where we are going wrong, and try and plug all the gaps so that the overall patient outcomes become better. So I strongly feel that teamwork, innovation, and relentless pursuit of achieving better outcomes, actually that made all the difference. So here I would just leave with the last slide, where after 15 odd years of implementing these protocols, this is the difference we could see. And what matters to patient at the end of the day is how well they can go back to their normal lives, what they were not able to do earlier. Now they are able to do everything without pain. So these are some typical examples of varus knees which usually come to us. And this last patient which I have just met is an Indian football coach, and he was having significant disability. He wanted to go back to football. We were not, hopeful, but with all the physiotherapy and the teamwork, this is where he landed. And every year he comes to India and shows how well he has returned to all the normal activity what he used to do once upon a time before the knee replacement. Thank you so much.
Thank you, Dr. Aashish. First of all, seeing is believing. Rather than having words, showing the video was the most thing which we will carry back. I remember those days when it used to be 1 week, and now we are looking at 2 to 3 days, and it's an amazing work. And secondly, for the time, you have really managed that very well and delivered the message effectively. Thank you so much. Thank
Thank
you.
you.